and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shanmugam. What is failure? Some will say it's the first attempt at learning. Thomas Edison, the prolific inventor, is often quoted as saying, "I have not failed. I just found 10,000 ways that do not work." But yet in medicine, we tend to shy away from publishing negative studies. Economist and statistician Tim Harford writes about this issue in his book, The Data Detective: 10 Easy Rules to Make Sense of Statistics. He says, those of us who write about research have a similar responsibility, not just to report on a stunning new result, but to set it in the context of what has been published before, and preferably what should have been published but languishes in obscurity. The manuscript we will discuss today is Clinical and Biomarker Responses to BI 655064, an antagonistic anti-CD40 antibody in patients with active lupus nephritis, a randomized, double-blind, placebo-controlled phase 2 trial. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm happy to be joined by the manuscript's first author, Dr. David Jayne. Dr. Jayne is a professor of clinical autoimmunity at the University of Cambridge and director of the Vasculitis and Lupus Clinical Service of Adam Brooks Hospital in Cambridge, England. Trained at the University of Cambridge and in London, England, he also completed nephrology training at Harvard University, the other Cambridge, in Boston, Massachusetts. He was co-founder and president of the European Vasculitis Society and is a fellow of the Royal College of Physicians and a fellow of the Academy of Medical Sciences, an independent expert voice of biomedical and health research in the UK. Dr. Jayne has coordinated a portfolio of interventional clinical trials, studies in biomarkers, histopathology, and clinical epidemiology in vasculitis and lupus-centered kidney injury in autoimmune disease. Welcome to the show, David.
So, Vicky, many thanks for the introduction, and thank you for the invitation to talk about this study. And I hope during our discussions, I'll be able to demonstrate that failure is not always a failure.
So the drug in this study is known only by its number, BI 655064. What is it? Can you tell us about its mechanism of action?
Yes, the title is a little bit of a mouthful. But BI 655064 is a second-generation humanized antagonistic anti-CD40 monoclonal antibody that is designed to block the CD40-CD40 ligand interaction. CD40 is a transmembrane cell surface receptor belonging to the co-stimulatory molecules of the tumor necrosis family. CD40 is also expressed on B cells, dendritic cells, and monocytes, and the interaction between CD40 and its ligand plays a critical role in immune regulation. CD40 activates proliferation, differentiation, and immunoglobulin production in B cells. And in lupus nephritis, CD40 ligand-mediated activation of myeloid cells and various other cell types within the kidney amplifies the inflammation in the glomeruli and tubulointerstitium. Therefore, targeting the CD40-CD40 ligand pathway seemed to be a promising approach for the treatment of lupus nephritis.
So this is not the first agent, though, targeting the CD40 ligand pathway. There was a prior agent, I believe it's BG9588, which was investigated and showed potential benefit in serologic markers in proliferative lupus nephritis. But the trial was stopped due to thrombotic events. What's different about BI 655604?
Yes, you're absolutely right. And in fact, the preliminary results of that study were quite interesting for lupus nephritis. And the explanation for the thrombotic events was a cross-reactivity between the CD40 ligand antigen and an antigen on platelets. So the therapeutic antibody caused platelet aggregation and hence the thrombotic events. BI 655064 targets CD40 rather than the ligand, but it also has mutations in the FC region of the antibody that prevents FC-mediated antibody-dependent or complement-mediated cellular cytotoxicity and platelet activation. So if you like, silences the FC region of the molecule. And in vitro, BI 655064 caused no platelet aggregation. And in prior clinical studies in healthy volunteers and rheumatoid arthritis patients, as well as in lupus nephritis patients, this molecule did not cause any thromboembolic events. It appears to be clear of that particular complication.
Great. Thank you for that background. So can you walk us through the design of this study? In particular, who did you enroll? What was the drug dosing? And how did you stratify, particularly for race and then baseline proteinuria in the randomization?
So it's important to appreciate that this was a phase 2 dose-ranging trial in lupus nephritis that was both proof of concept in terms of impact, particularly on biomarkers, as well as a phase 2 design looking at clinical endpoints, which would then be used to power a larger phase 3 trial. So the trial had a number of objectives. It was a randomized, placebo-controlled, double-blind study, and it enrolled patients with active lupus nephritis from over 70 sites in 20 countries, North America, Europe, and Asia. Patients were aged between 18 and 70, and lupus at that time was defined using American College of Rheumatology criteria, and they, in addition, had to have either positive anti-double-stranded DNA or be ANA positive. This was a nephritis study, so for entry into the study, the patients had to have proteinuria of at least 1 milligram per milligram and a kidney biopsy within the previous 3 months, demonstrating active lupus nephritis, ISN-RPS, that's the current classification system of class 3 or 4, with or without class 5. So patients with pure class 5, so-called membranous lupus nephritis, were excluded. And we also excluded patients who had had a recent course of induction therapy for lupus nephritis within the previous 6 months. They were randomized 2 to 1 to 1 to 2 to 4 groups, placebo or 3 different groups of the therapeutic antibody, 120, 180, or 240 milligrams, given subcutaneously every 2 weeks. And this was given on top of mycophenolate mofetil dosed 2 to 3 grams per day, methylprednisolone pulses, and oral glucocorticoids, a typical standard of care combination therapy at the time. And it's always important to appreciate when looking at lupus nephritis studies, their designs are typically add-on studies. So this is not test medication versus standard of care. This is a standard of care plus test medication versus standard of care plus placebo. And that causes a number of problems in interpreting results. So the trial was powered to reject the null hypothesis of a flat dose response curve under the assumption the placebo response rate would be about a quarter, about 25%, and the treatment benefit would be an additional 20%. So we were hoping to detect quite a big benefit, moving from 25 to 45%. And with the sample size of 120 patients, that was 40, 20, 20, 40 in the 4 groups, we had about an 82% probability of demonstrating this difference according to the power calculations.
Yeah, and tell us a little bit then about the secondary endpoints. You had a few secondary endpoints and then additional endpoints of interest, if you could share those with us.
So the primary endpoint was the proportion of patients with a complete renal response at 52 weeks, and that was defined as a proteinuria less than 0.5 milligrams per milligram and essentially stable glomerular filtration rate. Secondary endpoints were complete renal response earlier at 26 weeks and partial renal response, which was really a 50% reduction of proteinuria to subnephrotic levels at weeks 26 and 52. There were additional exploratory endpoints, including time to complete renal response, change in the disease activity score, SLEDAI, and its renal and non-renal subscores, and in patient-reported outcomes, particularly the Lupus Pro and the FACIT-F for fatigue.
So let's talk now about the patients enrolled. I think you'd covered already, it's a multi-center study. You had about 74 sites across 20 countries, and the time period was August 2016 to August 2020, so kind of just overlapping with that beginning of the pandemic. Tell us about the demographics of the patients enrolled.
Well, I think the first thing to say is it took a while to enroll the study. And this speaks to the complexity and difficulty of doing lupus nephritis studies and has been faced frequently, particularly for phase 2 studies using novel therapeutics. So 121 patients were enrolled and received at least one dose. And patient age was typical for a lupus nephritis cohort ranging from 24 to 47 years. Most patients were female. And we had a reasonable proportion of Asian patients, reflecting really sites where patients were recruited from of around 40% per group. Most patients, according to the local pathologist, had lupus nephritis class 4. That's typically what you find in a lupus nephritis population. And we calculated by central evaluation activity scores and chronicity scores for the biopsies. And this was particularly important because we saw an imbalance with higher chronicity scores in some of the active treated groups and lower chronicity scores in the placebo group. And this, again, speaks to the problem of lupus nephritis trials. There are so many baseline variables to try to balance, and you can't really stratify by histologic variables because you don't get the central review until sometime after the patient has been enrolled. And we know that baseline chronicity scores are going to impact on the chance of that patient achieving the primary endpoint. So this was a big problem. The other key feature of the demography is that more patients in the placebo group had a short duration of lupus nephritis, less than 6 months. And we know that disease duration, again, is a predictor of response, with those with the longer duration having a lower response.
Yeah, so all important points. You also had a pretty high dropout or discontinuation rate. Can you talk us through your thoughts as to why that might have been?
I mean, it was high for a clinical trial, but it wasn't particularly high for a lupus nephritis study. Even if you look at recent phase 3 trials, such as the BLISS-LN, there was around a 30% dropout in that study. In this study, the dropouts were varied between groups. It was about 15%, between 15 and 30% in the different groups. Reasons for discontinuation were mainly adverse events. And this is not adverse events to the test medication, it's adverse events to the whole cocktail of drugs patients are receiving, including mycophenolate mofetil and glucocorticoids. And again, this is really not unusual. And one of the problems with powering these studies, and one of the reasons that so many lupus nephritis studies are negative, is that dropouts have to be considered as treatment failures, yet the dropouts are usually not for any reasons to do with the therapy that you're testing.
Yeah, again, another really important point. So let's talk about the data. Your primary endpoint, as you said, was the complete renal response at week 52, as you define that as proteinuria less than 0.5 grams per day and a GFR of greater than 90. Tell us what you found and walk us through the graphics in figure 1.
Yes, so essentially the primary endpoint was negative. And if you look at figure 1A, it shows the proportion of patients achieving a complete renal response at week 52, which was actually 48% in the placebo groups and between 38 and 44% in the test groups. So really no difference between any of the groups. Figure 1B shows the secondary endpoint of the proportion of patients achieving this response at week 26. And here, this was only 37% in placebo, but was actually 50% in the 180 milligram group. And one of the consistent features of this report is the results of the 180 milligram group. Essentially, we saw nothing in the 120 milligram group in terms of efficacy, and we saw a falling off of efficacy and more toxicity in the 240 milligram group, but the 180 milligram group appeared to be the one that came through best. But overall, no statistical significance. And figure 1C just uses a different estimate of proteinuria using spot urine. And again, this showed around a 50% response for the 180 milligram group, 42.5% for placebo. Again, this all speaks to the problems of lupus nephritis trials in terms of when do you choose your endpoint? How do you measure proteinuria? This can have big effects on the delta, especially if you're dealing with relatively small patient groups.
I'm going to jump forward a bit in your analyses now, although I will come back to a couple of those points you just made. But One of the reasons why the study team postulated that the primary endpoint was not met was related to this higher than expected response in the placebo group. So you did some post hoc analysis on that. Can you talk us through those findings?
Yes, this was unexpected, and there's been quite a few publications looking at placebo response rates in a number of clinical trials, and our estimate of a 25% predicted response rate was not that far off what you can see in the literature. But we think that the unexpectedly high response rate that we saw prompted the use of further post hoc analyses to try to understand whether there was really useful differences. And we used an endpoint called confirmed clinical response, which essentially means you get into clinical response by week 46 and you stay in it out to week 52. And using this endpoint, actually, the placebo response rate came down to 29%, and the 180 milligram group was 44%. And this is approaching statistical significance. So this again points to the problems of what endpoints do you choose in lupus nephritis studies.
You also drilled down a little bit further into some of the additional endpoints, and something does seem to have come up both in the protein creatinine ratio results, the Selena-SLEDAI scores, and the health-related quality of life scores. Can you tell us what you uncovered there?
Yes, clearly, if you do think you're observing an effect of a drug, and you're using multiple dimensions to try to estimate this, it's nice that they all move in the same direction. And that's broadly what we saw in this study. And the lack of statistical significance is more a numbers and a power issue. But proteinuria is the key response biomarker in lupus nephritis trials. And when we looked at change in proteinuria over time, the 180 milligram group clearly stood out, and this is shown in figure 2 in the paper, as having the biggest reduction in proteinuria. We also looked at Selena-SLEDAI, and this change in Selena-SLEDAI is typically used in phase 3 trials of lupus, typically a 3 or 4 point change. And when we looked at changes in Selena-SLEDAI, we saw a slightly higher change for the 180 and 240 milligram group of around 80% compared to about 50% in the placebo group. So this is looking at the totality of lupus activity. And at week 52, when we separated the renal and the non-renal scores, we saw the similar differences. So this wasn't just confined to one particular organ system.
So actually that brings me to my next question. Let's talk about the pharmacokinetic and immunogenicity data, because it seems like the pharmacokinetics of this agent might be non-linear. Can you explain that to our listeners?
One of the problems of using a therapeutic antibody in a patient with nephritis is that you get clearance of the antibody in the urine, which complicates the pharmacology. And there's been a recent demonstration of this in an anifrolumab study. That's an anti-interferon drug used in lupus nephritis. But here, we found these so-called non-linear pharmacokinetics in healthy volunteers. And the reason for these so-called non-linear kinetics, we think, is because of the distribution of the target and the wide distribution of CD40 receptors, particularly platelets, which have a short half-life. And this has been reported in other studies with antagonistic CD40 antibodies. So, in other words, we think this is something to do with the function of the target antigen for the monoclonal rather than a conventional clearance of the drug.
Interesting. So maybe this will be a situation where there's some way to measure that, perhaps in potential future studies?
Yes, absolutely. And another aspect of monoclonal antibodies with anti-drug antibodies, and we know that anti-drug antibodies tend to shorten the half-life of monoclonal antibodies. And we found anti-drug antibodies in around 7% of patients in this trial, but it wasn't clear to what extent this affected the pharmacokinetics in the groups overall. There were individual patients in whom there appeared to be a reduction in the concentrations of therapeutic antibody with ADAs, but numbers were too small to make any general conclusions.
So let's talk now about biomarkers, because all the patients in this study, including those in the placebo group, did show a drop in their double-stranded DNA levels, presumably because they were receiving a standard of care in addition to the investigational drug. Were there other thoughts about why that might have been?
And this speaks to the point we were discussing earlier of the add-on design, and absolutely steroids and mycophenolate will depress anti-double-stranded DNA antibodies. But actually, we observed a greater reduction in anti-double-stranded DNA antibodies in the 180 milligram group. And going back to the mechanism of this drug is designed to disrupt T-cell, B-cell co-stimulation along with interactions with other inflammatory cells. So we would expect to see an impact on B-cell activity and autoantibody production. But the increased effect on the 180 milligram group fitted with the therapeutic effects on proteinuria that we saw.
In the supplementary data, you also talk a little bit about that double-stranded DNA level and then also the complement levels. Do you kind of have recommendations on how to interpret that data, both as a study team member and then also as a clinician looking after patients?
So clearly, autoantibodies and complement levels we use in the evaluation of lupus nephritis, and we use in the assessment of treatment response. And there's clear data showing that early normalization of complement levels is a good predictor of a later proteinuric response. However, many studies of B-cell targeted therapies and co-stimulatory targeted therapies, such as with rituximab or abatacept, show a disconnect between effects of the therapeutic on serology, which tend to happen early, and effects on clinical endpoints such as proteinuria, which tend to happen late. So you have to be careful about inferring too much. I think the key point here is numbers were small, so we can't make general statements, and there's heterogeneity as to what the baseline levels of C3, C4, and double-stranded DNA are. But the 180 milligram group, if you eyeball the data which is in the supplement to the paper, showed the biggest beneficial effect on these parameters.
Sort of a teaser almost, something hopefully potentially may come out in the future. We've covered a lot of ground, but it's always important with a new agent to look at safety data. You mentioned earlier that adverse events were the main reason for discontinuation, I think in 12.4% of patients. You also picked up some concerning signals regarding infection risks, sepsis, and cytopenias, particularly in those higher dose arms. Can you talk us through the adverse event data?
So I think you're absolutely right to focus on this. And as a clinician treating patients with lupus nephritis, we're almost more concerned about the adverse effects of therapy than we are whether the treatment works or not. And clinical trials typically have serious adverse event rates of 15 to 25%. Fortunately, they weren't quite as high in this study. Infection is the most common adverse event that lupus nephritis patients suffer, and these were common in all groups, but they were numerically greater in the 240 milligram group, where there weren't differences between the 120 and 180 milligram groups when compared to placebo. Similarly, when we dive down into the infections, and particularly looking at opportunistic infections, these were rare, but there were 4 in the 240 milligram group, and they included 1 case of tuberculosis and 1 of cryptococcal meningitis, clearly both very serious opportunistic infections. Another adverse event of note that we saw, although the events again were rare, were episodes of neutropenia and lymphopenia in the 240 milligram group. You could say, fortunately, the most effective drug dose was the 180 milligram group. So we're seeing, whereas we saw a sort of bell-shaped curve with efficacy, with the best result at 180, with safety, we saw the most events with 240. And I think this is quite helpful data when it comes to choose a dose, rather, if this drug is going to be taken forward.
Just enough, just not too much, right? So it would be easy, though, to pass this trial off as a failure. Indeed, your abstract kind of states that this trial failed to demonstrate a dose-response relationship for the primary complete renal response endpoint. Does the study team think of this as a failure? What did you guys learn, and how are you planning to take that forward?
So in the supplement to the paper, you can also see effects on cell subsets. And this drug clearly had potent effects on B-cell subsets and CD40 ligand positive cell subsets. And if you put that together with the impacts on serology that we've talked about, And the somewhat weaker, but I still think real impacts on clinical endpoints, both SLEDAI and renal endpoints, there is efficacy here. Then if you put this in the context of lupus nephritis trials, and you have to realize that pretty well every trial up till 2020 in lupus nephritis was negative, even for drugs like rituximab, which we continue to use quite widely in treatment of lupus nephritis, we're very familiar with negative trials, or rather trials that fail to meet their primary endpoint. And this is as much an issue of complications of doing lupus studies and the inadequacy, if you like, of the current designs and the current endpoints. So my own take is that this study met one of its goals, which was proof of concept. We did demonstrate proof of concept in terms of all the biomarker work. It met the goal in terms of dose selection. There is a clear dose, the 180 milligram dose, that appeared to meet the best efficacy safety trade-off. What it failed to do was convincingly demonstrate a dose-dependent response. But given particularly the response on proteinuria as an isolated biomarker, in a way, I wasn't, it would be lovely to have seen a dose-dependent response on the primary endpoint, but I don't think this means that the drug doesn't work. And the issue of, whether the drug is going to be taken forward or not is very much a commercial issue for the company. But I do think, although the headline is it's a negative trial, we've learned a great deal about interacting with the CD40 ligand system in lupus.
And I love that you can kind of frame it that way. And if it's okay with you, I'd like to springboard from that to talking about the kind of larger issue in science of being willing to embrace quote unquote failures and see them as growth opportunities. You obviously are an incredibly accomplished physician scientist with training from the most renowned institutions in the world, years of clinical care and clinical trial experience. But I'm going to hazard a guess that you've experienced your fair share of failure. Our listeners love to hear about the people behind the papers. So I wondered whether you'd be kind enough to share any failures, big or small, that have shaped you and helped you learn over the course of your career.
So I think one point about doing a clinical trial is you are often defined by time, such as doing a 6-month trial or a 12-month trial, when the benefit may have a different timescale. And just with relevance to the study that we're discussing, we did extend treatment in many patients out to 2 years, and this confirmed benefits on some of the clinical endpoints that we saw. So there's that continued trend of benefit. I suppose the trial that's received the most discussion is a trial of plasma exchange and ANCA vasculitis that I led called PEXIVAS, which was a global trial of 700 patients trying to demonstrate that plasma exchange would lengthen the time to the composite of death or end-stage kidney disease. And we did not demonstrate that. We demonstrated a hazard ratio of 0.85, whereas we needed 0.67 to demonstrate statistical significance. And so this was reported as a negative trial for plasma exchange. But in lots of post-hoc analyses and meta-analyses and so on and so forth, there clearly is a benefit of plasma exchange on the kidney. And the mistake, if you like, that we made was going for this high bar composite endpoint of death or end-stage kidney disease, because we saw absolutely no impact on death. And death just served to dilute the endpoint. But there was an impact on end-stage kidney disease, particularly at 1 year. So we published a study that took 10 years to complete and included 700 patients as a negative study for plasma exchange. But we haven't really answered the question of whether plasma exchange works or not, and the community is still divided.
Yes. Oh, very divided. And I feel like that still comes up at the bedside quite a bit. So as a clinical trialist, you obviously work closely and collaboratively with many industry sponsors. And sometimes it's tricky to get stakeholder buy-in to publish what seem to be negative results. But the nature of science is that it's iterative. One study should build on another. So what advice do you give to both scientists and industry sponsors on being brave enough to publish data that did not support the original hypothesis?
I feel very strongly that there should be a compulsion that any trial registered on clinicaltrials.gov or an international trials registry has the results published. And the reason is, particularly in lupus nephritis, I've mentioned how hard it is to do these trials, but for each of these trials, we learn more, which enables us to be better and more efficient in clinical trial design. And, we have an ethical responsibility to do the best for our patients. And part of that is running the most high quality, most efficient clinical trials that we can. Now, this study, as well as learning about the therapeutic in question and the CD40 ligand axis, has added useful information about how you go about performing a phase 2 dose-ranging trial in lupus nephritis that the whole community is going to benefit from. And I have been involved in lupus nephritis trials, and I won't mention names, but at least 3 trials come to mind, which have been negative trials, but have been interesting studies, have consumed a lot of work, and the results are interesting and would be of help to be discussed by the community. So I really feel very strongly that these studies should go out. The other thing that industry tends to trip up on is that they often collect biomarkers and histology from these studies, but they usually do not do any work on them if the study is negative. Yet, as I've mentioned earlier, often you get a clinically negative result, but there's lots of interesting stuff with the biomarkers. So it would be really nice to see them pushing through biomarker packages, even in apparently negative studies, because we're all going to learn from the science.
Oh, I so agree. The other challenge we often face as scientists is actually persuading the journals to publish our seemingly negative results. So what would you say to journal editors and reviewers about the power of negative studies?
That's really not been my experience. And my negative studies have been as easy or difficult to publish as positive studies. And I think what this really speaks to is how much interest is there in the primary question. And if you can argue that your trial, if you can argue with the journal that your trial is trying to address an important question, that hopefully will be enough for the journal to at least have a look at what you're trying to do. So that's not been my personal experience, but I think this comes back to having a strong question for the trial. And we certainly don't want lots of low quality trials, out there. We really want to push the quality of trials up.
Yes, completely agree. David, I want to thank you for a terrific discussion today. I think it's very hard to publish negative studies, but so crucial for advancing the science. So thank you for everything that you do.
Thanks very much. I've enjoyed it and hope everybody enjoys reading the paper.
Today, my thank you goes to all those who fail. So, in fact, this thank you is to everyone. We all fail all the time in ways great and small, but those who take the most powerful lessons from their failures are those who can step back and view them through a different frame, not as a negative experience, but as an opportunity to learn something unexpected. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.